Hello, this is Sam Arbabi. I am professor of surgery at Harborview Medical Center at University of Washington. And today we are going to discuss pre-hospital management of patients with traumatic brain injury. As is stated on the slide, from now on, whenever I state TBI, I mean traumatic brain injury. Thank you. So the goals of talk are pretty clear. It's to describe the importance of pre-hospital care in traumatic brain injury and understand there are multiple methods of transporting a patient and how the care of the patients with traumatic brain injury at the scene does impact their overall outcome and their overall level of function. And as stated previously, the goal is not to encompass every kind of care. It is to brush upon some of the things that are important in care of traumatic brain injury patients. Also, I should mention that I have no stocks and no financial interest to declare in this talk. This is a slide for me to clarify that you can't generalize. Patients are very different from one patient to another patient. That makes medicine difficult and interesting. So there are some generalizations that are made here, but there are obviously exceptions to the rule depending on type of patients you have. Again, based on this slide, you can see you can have geriatric patients to young newborns, trauma, to blunt crashes, to various other kinds of injury. But here we're going to focus on traumatic brain injury and make few generalizations. But remember, again, patients are different and not all injuries are the same. To brush upon what are various modes of transport, basically there are two modes. One is by ground and one is by air. The ground transports, while there are various agencies with various levels of expertise, and one is very different than others. So you have AML, which is very different than when you have our medics in Seattle. All of these are different. But one of the main goals of all of these agencies is simply get patients rapidly to the hospital. So air transport is an important part of care. This is a map of Seattle, and this is looking at Airlift Northwest. Airlift Northwest gives you this, has multiple centers and tells you time to that center. For instance, if you look at the Yakima on this slide, it gives you 10 minutes to center, 20 minutes, 30 minutes, so you can see how it encompasses the entire state. Plus, if you look at the corner down here, Montana, Idaho, Washington, Alaska are involved in it. And air medical transport becomes very important in management of a lot of patients, including patients with traumatic brain injury. So what do trauma patients die from? Obviously, one of the things that people always focus is the second one on the list is blood loss. And especially acutely, when patients come in within the first 48 hours, that blood loss is one of the major causes of injury. We are impacting on that significantly with the new methods of tourniquets to stop the bleeding, stop the bleed programs to teach everybody how to stop the active bleeding, various methods of transporting patients, and various resuscitations with earlier blood and blood products. We are having a significant impact in this group. Many of them do require surgical intervention, and this is where the trauma surgery team comes in for rapidly getting them to operating room where the bleeding that is source, the stopping that would be the key. But very soon after, brain injury becomes one of the main causes of death. And in fact, when you look at overall trauma care, brain injury is one of the highest causes of brain death or disability in trauma patients. The last one on this slide, which is not focus of this talk, is multiple organ failure. This is when systemic inflammatory response kicks in. And we are getting better at that one also. But again, the focus would be the brain injury. Here stating that brain injury is one of the main causes of death and disability in trauma patients. When we talk about trauma in general or in medicine, the acronym ABC comes in, and A always stands for airway in this situation. Controlling airway is paramount, it's your number one goal. Why? It's because if you don't have airway, you can die within several minutes. And then we go to breathing. And here we will discuss what is ventilation and what is oxygenation. I will brush upon what are the importance of each, especially as it relates to traumatic brain injury. Circulation, or how the blood flows and gets oxygen to your tissue, is very important. Getting that oxygen to the brain is one of the main goals of care of trauma patients in general. We will also discuss some of the things, products that can help with stopping the bleed or decreasing the size of hematoma in the brain, or in general stopping the bleed, because it can help two ways. By stopping the bleeding in the brain, you decrease the size of the mass, which is the blood clot. And by decreasing bleeding from everywhere in the body, you improve the oxygen delivery to the brain by keeping the blood pressure okay. We will discuss all of those in the next few slides. The goals of resuscitation, and this is limited, but one of the main goals of resuscitation is, and it's always, is to get adequate oxygen delivery to your tissue. The main tissue that we always focus on is brain. It's a tissue that without brain oxygen, it can die within several minutes. The goal is to stop the bleeding, hemorrhage control, so your blood pressure is okay, so you have enough circulation, so you can get the blood to your brain. Restoring tissue perfusion, meaning that after you stop the bleeding, you have lost a significant amount of blood, or while you are losing blood, to replace that until you can stop the hemorrhage. Correcting coagulopathy, will brush up on that because many of the trauma patients have coagulopathy. And that coagulopathy will cause more bleeding. And the bleeding can have an impact on the brain injury in two folds. One, again, the size of the hematoma in the brain. If there is coagulopathy, as in you cannot stop the bleeding, the size of the hematoma in the brain increases. And also, if there's any other source of bleeding, bleeding from these sources will bring your blood pressure down, circulation down, and the tissue oxygen delivery will decrease and brain will not get enough oxygen. We talk about preventing hypothermia. Why in trauma hypothermia is important is because it's part of what we call C circulation, again, as the slide you saw before. Hypothermia, especially temperatures below 34.5, can induce significant coagulopathy and bleeding. And again, bleeding, if it's in a closed space like brain, or bleeding in the abdomen or chest, is not a good thing because it can cause major secondary injury to the brain. I will discuss secondary injury to the brain in this talk, and we will see how we can prevent that. Secondary injury to the brain. So when there's trauma, there is an initial damage to the brain. So the brain tissue is damaged, and some of it is dead. The necrotic brain tissue or dead brain tissue, we cannot restore it. It can never recover. However, the tissue surrounding it may be alive, may be somewhat ischemic, so we want to get blood flow to it. Also, if there is any edema or swelling of the brain or bleeding, that would cause increase in mass or increase in size of that tissue. That increase in size in a brain vault that is closed space would cause pressure. That pressure, which we can call it intracranial pressure, would exert negative feedback on the blood flow, because the blood flow has to fight that pressure, and it will decrease tissue perfusion and can cause secondary brain injury. So our goal is to keep oxygen delivery to the tissue with minimal swelling of the brain and keeping the intracranial pressure down. So both of those. So therefore, when you look at brain injury, and I know others discussed this in previous talks, the regulation of the blood flow to brain is well controlled, except when there is trauma. That control almost becomes an issue, and therefore keeping the blood pressure up becomes the most important part. Dr. Chestnut, who's going to give one of the talks, was one of the initial people look at hypotension. Hypotension in brain injury is disastrous. It doubles your mortality, and it causes more secondary brain injury because, again, the blood flow to the brain will decrease. The goal of the pre-hospital providers is to avoid that hypotension, keep the patient's blood pressure adequate so they get blood perfusion to the brain and get oxygenation of the brain. When we talk about oxygenation, obviously you need the blood flow to the brain, but that blood has to have oxygen in it. So the oxygen delivery and hypoxia or lack of oxygen in the blood would be a bad thing, and it can cause ischemia. Also, we will talk about regulation of this blood flow, and a lot of it is related to CO2 or carbon dioxide. Hypercarbia or increased CO2 is bad because it causes increased size of the blood volume in the brain and intracranial pressure, causing pressure in the brain to go up, therefore decrease the blood flow. It is also very interesting, and it will become a main discussion in our talk, that hypocarbia or hyperventilation, causing more ventilation so your CO2 comes way down, may also be significantly deleterious in cases of trauma, especially with traumatic brain injury, because that would cause vasoconstrictions of the blood vessels that go to the brain, and that vasoconstriction will decrease. By vasoconstriction, meaning the blood vessels get tight, decrease blood flow to the brain and can cause problem. There is a sweet spot between too much CO2 and too little CO2 that we always aim for. And as discussed, we want to decrease cerebral edema or blood clots in the brain. So we don't want the bleeding to continue in the brain. So if the patient has coagulopathy, disorders of clotting, that can significantly impact that, because the size of the hematoma growing would cause, again, higher pressure in the intracranial vault and increase your intracranial pressure, decreasing the blood flow to the brain and causing secondary brain injury. So as we'll discuss, people who are on blood thinners, such as Coumadin or warfarin, or the newer oral anticoagulants, would be at higher risk because the hematoma or the bleeding in the brain can increase in size. So we discussed that when there's trauma, there is an initial damage to the brain, and the cells that are dead, they are dead. We can't bring them back. But our goal is to avoid any further cell death, or lack of blood flow to that brain cell will cause cell death. So we want to avoid that. So we want to keep the perfusion up. Also, we want to avoid hypotension, because the regulation of the blood flow to the brain is dysregulated in traumatic brain injury, and it is directly related to your blood pressure. So if your blood pressure drops in traumatic brain injury, your flow will drop. So we want to avoid hypotension. That's one of our main goals. We also want to keep the blood oxygenated so oxygen can get to the brain. So we want to avoid hypoxia, lack of oxygen. We want to keep the carbon right at normal carbia, as in we want the CO2 to be at the sweet spot. I will discuss this more. We don't want it too high because the intracranial pressure go up, and we want it too low because then the blood flow to the brain will be compromised because of vasoconstriction of blood flow. So in pre-hospital providers, there is a lot of controversy regarding intubation, especially as it relates to traumatic brain injury. It is very clear to everybody, however, that if you don't have an airway, as in your airway is obstructed, that you have to get a control of the airway, because without an airway, several minutes later, the brain is dead and you're dead. So if you don't have an airway because you have vomiting, blood is in your airway, you cannot clear it, or your mental status is so bad that you cannot keep the tongue from falling and blocking it, and you cannot protect your airway, most people would tell you that you should intubate the person, as in put an endotracheal tube in the brain, in the trachea, protecting the airway, therefore keeping oxygenation going on, therefore getting adequate oxygen to the tissue and the brain. We will discuss avoid hyperventilation in next slides. As I told you, there is controversy because there were few studies done, especially one from San Diego, that looked at patients that got intubated. And many of their patients, during intubation, patient was not paralyzed, and the intubation was therefore difficult. And they have demonstrated that, especially in a group of patients that were hyperventilated, that they required, that they were being bagged too fast, therefore their carbon dioxide dropped to a lower level. These patients did not do well. Other groups of people studies have shown that when you intubated at inappropriate with RSI, rapid sequence intubation, as opposed to bag valve mask ventilation, BVM, actually patients did a lot better. Now, there are multiple differences from one place to another place. And you have to look at your system. Are you trained to intubate patients? Do you know how to do rescue intubation? Do you have other methods of keeping airway controlled? Can you follow these patients? Can you do them in a rapid sequence without delaying patient getting to the hospital? So let's look at this summary slide. It says that, and it's a generalized statement, but if you are going to intubate at the pre-hospital as a pre-hospital provider, you have to have training and skills to do the intubation. And that will include neuromuscular blockades, because various studies have shown that intubation of many of these patients without neuromuscular blockade is fraught with problem and very difficult. You have to have ongoing training in operating room or as a skill maintenance, and you have to be able to do quality assurance with the appropriate feedback. There has to be also availability of rescue devices for difficult airway. For instance, in our system in Seattle, medics or King County medics, they follow all of these routes. They are outstanding in intubations. They are a group of people who are highly skilled and some of the best in the country and the world. And the reason they are the best is because they follow all of these. They're always in the operating room, they're getting recertified, they're working, they intubate the patients regularly, they have quality improvement program with feedback. And that's why the outcome of patients that get intubated at the scene at our King County, Seattle area is outstanding. The breathing part is, so you got the tube in the endotracheal tube and you're ventilating and oxygenating the patients, but the lungs are become important. Are the lungs, do they have a pneumothorax or hemothorax? We have to manage those, be able to oxygenate and ventilate the patient. The ventilation, almost everybody knows what oxygenation is. It's the amount of oxygen in your blood, which is attached to the hemoglobin, so hemoglobin saturation. Saturations above 90s, 92% is great, and that will have oxygen in your blood to get to your tissue. So if you have perfusion and you're pumping good cardiac output with good blood pressure in case of traumatic brain injury, you will get good oxygen to the tissue. However, there is another part. It's called ventilation. One of the jobs of the lung is to get the CO2 out of the system. Many of the systems in the body is tuned to CO2 because CO2 correlates with the pH of the body very closely. So if you ventilate too much, as in you push that bag and continue to push it too fast and breathe too fast for the patient, then you will hyperventilate. That would mean that you clear the CO2 too fast, so your CO2 will go down, which means that your pH will go up, and also by doing that, you will cause vasoconstriction of blood vessels that go to the brain, and that's not a good thing. So the question is, what is an optimal PCO2 that we're going for? And various studies looked at it. This would be one. And when they looked at this CO2, if you look at the top, it talks about hypocapnia, meaning too low of CO2, carbon dioxide. Here, less than 30. The target being 30 to 35. Most people widen that target. Some talk about 33 to 36 to 37. That target has been discussed and it could be variable. In general, people talk about targets somewhere in the mid-range of 33, 35, 36 to 37, to that range. When we look at that target, and you can see that about only 16% of the mortality rate for that target was the lowest, was 16%, compared to others, too high, which was 26 to 36%, and too low, which was 25%. So you have a sweet spot in that target range. And the mortality rate is significantly decreased. But when you look at how many people were actually in that target range, you'll see that not many if you don't pay attention to it. So when you look at the after adjustments, if you are in the target range, your mortality rate drops to 0.56. So it's basically 40% reduction in mortality if you can get your ventilation or your CO2 in the target range in patients with traumatic brain injury. So hyper and hypo, too much CO2 and too little CO2, are common. Only about 30% of patients are in the target range, and those can significantly affect the outcome of traumatic brain injury. So how can we adjust how much we're going to press that mask, the bag valve, sorry. How many times are we going to ventilate the patient? Is there a method to do that? Well, there is a capnography. The gas that comes back has the CO2, and we can see what that CO2 level is, which we call it end-tidal CO2. And that in the normal physiological responses, people who are not sick, correlates well to the CO2 of the body. So we can continuously check that and say, okay, we are hyperventilating or hypoventilating. And that would really be great. Except there is a but coming here. If you look at end-tidal CO2 studies, which was done, many of it was done at Harborview Medical Center by Dr. Eileen Bulger and the team here, it becomes clear that certain group of patients don't do well. And by the way, I should acknowledge that a lot of these slides that you see today are from Dr. Bulger, so thank you, Dr. Bulger. When you look at these patients and you look at their end-tidal CO2, an interesting thing becomes clear. So this graph is quite busy, but I don't want you to focus on everything else, except look at the correlation of PaCO2, that is the carbon dioxide in the blood, and end-tidal CO2, the carbon dioxide that comes out of the endotracheal tube. That you can see the one that is isolated head injury, the one that is red and the box isolated head injury, it's a great correlation. R2 is 0.78. But when you are in shock and when you are hypotensive, in fact, your correlation is not good at all. And your end-tidal CO2 drops in these cases. The reason end-tidal CO2 drops in these cases is that the perfusion, because you're in shock, the perfusion of lungs decreases also, so the CO2 doesn't get clear, so your end-tidal CO2 would be actually low. It is, in fact, a sign that the patient is in trouble, so having low end-tidal CO2s is a bad sign, and doesn't correlate really with the CO2 of the blood, and it's a different marker. So it's a good marker to know a patient is sick, but in patients that have other injuries, end-tidal CO2 may not be a good way to target your how much you ventilate the patient. If you have an isolated head injury that is not bleeding, then maybe you can use it. But in trauma, it's very difficult to know if you have other injuries, is this isolated or not. So keeping the person in that target range will require significant education, significant understanding that in stressful situation, you may want to continue to ventilate the patient, hyperventilate, and you should avoid that because you don't want your PCO2 to be too low. Also, end-tidal CO2 may be beneficial in isolated head injuries, but in patients that are in shock, it's a poor correlation. In fact, low numbers are suggestive of bad outcome because it may suggest shock in those patients. So the bottom line is, if you can improve oxygen delivery to the tissue, it is your goal. In patients that don't have an airway, you have to intubate them because without an airway, they can't oxygenate or ventilate. And you saw that, that too much CO2 is just as damaging or worse than hyperventilation. And lack of oxygen would be a key factor to your heart and brain and will stop. So if there is no airway, you have to intubate. We discussed that you have to have a system of care for if you're intubating as a pre-hospital provider, and that system has to have qualifications that we already discussed. And then after you intubate the patient, you not only have to pay attention to oxygenation, which is how much oxygen they're delivering and what is their saturation, but you have to pay attention to their ventilation. What is their PCO2 or their CO2 in the blood? The oxygenation is easier system. You can look at the pulse oximeter and you can continuously monitor it, but we don't have a system currently to monitor the continuous PCO2 without any invasive system. So you may need arterial blood gases that are routine and rapid to see where your PCO2 is, especially if the patient gets to the ER and you want to know where is my PCO2, that will really help you. Also, the pH that you get from arterial blood gas will help you tailor your resuscitation. We also talked about coagulopathy, and that in traumatic brain injury is important, and it also comes back to the pre-hospital providers, because there are multiple ways that you can induce coagulopathy in trauma patients, and it's very common, and here the slide says 25%, and occasionally in severe trauma it's even more than that. And coagulopathy can be induced in various ways. We talked about low temperature, which below 34.5, the blood clotting system does not work. So the pre-hospital providers have to avoid hypothermia. We also talked about that there are some patients that, due to significantly nowadays due to atrial fibrillation, they take, or it's a heart arrhythmia, they take medication to thin their blood or make so they can't make clots and avoid strokes. But the side effect of those medications is that when bleeding happens, they are hypocoagulable. The coagulation system doesn't work, and therefore the bleeding would be more. Especially if you have a traumatic brain injury, even if that increases the bleeding in the brain slightly, that could cause significant mass effect. And by causing significant mass effect, you will have more decrease in blood flow, more ischemia, more swelling, and more bleeding, and therefore it can cause a vicious cycle. So you want to avoid those. The other method that we cause coagulopathy that we haven't talked about is giving too much resuscitation with fluids instead of blood and blood product, and that would dilute the blood and clotting factors, and therefore will induce coagulopathy. So nowadays, in order to avoid that coagulopathy, we start with blood and blood products early, not to lose the clotting system and avoid the coagulopathy. One of the things that we talked about is blood and blood products, plasma. We used to have blood in the airlift. Now, in addition to blood, we will have plasma. This shows plasma being given to a patient in Airlift Northwest. Hospitals have also prothrombin complex concentrate. Currently, most of our medics don't have it. And that can also reverse some of the coagulopathy induced by medications such as warfarin or Coumadin. I'll talk about tranexamic acid separately within the next few slides. We talked about avoid dilution and avoid hypothermia already, and those are very important as a pre-hospital provider. Tranexamic acid is an antifibrinolytic agent. By that it means that it blocks plasminogen binding sites or plasmin binding sites. So the plasmin causes fibrolysis or dissolves the fibrin in the body and opens them up. And this inhibits that, therefore makes the clots form better and much more vigorous. So it may reduce bleeding, mortality from bleeding. There was a famous clinical study which is called CRASH, and you can see the acronym on the slide, a clinical randomization of antifibrinolytic in significant hemorrhage 2. And that CRASH study looked at trauma patients and showed that the mortality, absolute mortality, reduced from 16% to 14.5% when it's given early, as in within the 3 hours of the injury. Tranexamic acid in TBI may improve coagulopathy. And again, if it decreases bleeding, especially if it's bleeding in the brain, that it just a little bit can decrease the intracranial pressure and decrease the mass effect, therefore improve oxygen delivery to the brain tissue. This CRASH-2 study couldn't say whether there was any benefit. The mortality rates for TBI went from 6.2 to 6, which wasn't statistically significant. And review of studies that demonstrated the CRASH-2 can't say if tranexamic acid is good or not. Currently, and I think it's ongoing or may have closed it recently, there is a study going on with tranexamic acid as a pre-hospital providers, giving it to patients with traumatic brain injury, to see whether giving it early, especially at the scene, will have some effect. This may become something new in the future. Currently, it's not standard of care as the pre-hospital providers. But most hospitals now give it when there is a massive transfusion. A lot of hospitals also give it with a GYN emergencies and bleeding from spine operations and as such. So take-home message for all of, so we come to the summary of our talk. So the take-home message for our talk is simple. intubate for inability to protect airway. If they can't keep the airway open, then you have to intubate. But only do so if you have a system of support for pre-hospital intubation, such we have in King County and Seattle. Again, it's true pleasure to work with pre-hospital providers in our system because they are truly outstanding. But that requires a lot of work. And I again refer you to the slide that I showed you, but you do need QA, you do need practice, you need to continue to have systems of rescue airways, and that becomes very important. We talk about there's a sweet spot, a Goldilocks, if you want to talk about it. There's a sweet spot between too much ventilation and too little ventilation. You have to provide oxygenation, which you can look at it with SAT monitor. But in addition to that, you have to clear the CO2, which is ventilation. But the ventilation, if you do it too much, take too much CO2, ventilate them too much and hyperventilate them, take the CO2 out, their CO2 drops, and that constricts the blood vessels that go to the brain. That's bad. And if you do too little, the CO2 will go up, that increases in intracranial pressure, that presses on the brain. And again, brain doesn't get enough oxygen or blood flow, and that is bad. So you have a Goldilocks zone. It is difficult to have a method. Currently, end-tidal CO2 in multi-trauma is not a good method, but training and knowing what to do will become important in these cases. Ultimately, one of the main goals is that none of these therapies should delay the patient getting to the hospital. So rapid transport, and depending on where the patient is, that may be air transport, that may be ground transport, rapid transport of the patient to the final destination becomes very important. So avoid delays. I want to thank you all. This was just a glimpse at pre-hospital provider care of traumatic brain injury. I had to focus on few areas, so I did not mention many other areas. In half an hour, obviously, we don't have enough time to go into all areas, but I wanted to focus on some areas and provide you with some insight in that. Also, as I mentioned, it is trauma in general, and especially traumatic brain injury, is a team effort. From the pre-hospital providers to hospital people, from ED to OR to angio to nurses to ICU care to floor care. And then the rehab part becomes very important with the rehab team involved. So that, and multiple teams are involved in care of these patients and at various processes. So it's truly a pleasure to be part of the team, especially with the group of pre-hospital providers that we have in our area and Seattle Medics. Thank you for your time, and I appreciate it.